Hello and welcome to the Alabama Public Health Training Network. I'm Tim Hatch with the Center for Emergency Preparedness at the Alabama Department of Public Health. Thank you for joining us today for our program, Chemical Warfare, a primer for first responders and receivers. If you have a question about anything being discussed today, please call or email during our podcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You'll need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, and EMS personnel for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on April 30th, 2020, and 2 years for social workers and EMS, expiring on April 30, 2021. If you're watching this program on demand and want to receive a Social Work CE certificate, you will need to complete the social work test and send it in along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching it on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our presenter for today. Dr. Zaid Kazi is an emergency physician and toxicologist at Emory University. He is also president of the Middle East and North Africa Clinical Toxicology Association and adjunct associate professor for the American University of the Medical Center in Beirut. Welcome, Dr. Kazi, and thank you for being with us today. I know you've got a tremendous amount of material, so let's get started.
Thank you, Tim. It's a pleasure to be back here at the studio. This is my fourth satellite broadcast from Montgomery, and it's a pleasure to be here. This year I'm actually here representing the UAB Research Center for Excellence in Arsenicals. This is an NIH-funded center since 2018, and it's down the street in Birmingham.
Right.
This center is doing a lot of work, important work in researching new drugs and medical countermeasures for the treatment of arsenical warfare agents. And if anybody has any questions about that, they can go to our website and learn more about it. The importance of this topic is very clear in view of recent events, as you know. And if people want to comment about any of the content that I present, they can do that also using social media. They can use my Twitter account and use the hashtag @UABCounteract if possible. So you mentioned that I'm a medical toxicologist, and I actually trained in Atlanta at Emory between 2003 and 2005. I did my fellowship in medical toxicology. And of course, when you are a fellow in medical toxicology, you learn about chemical warfare agents. And I became a hazmat instructor using the Advanced Hazmat Lab Support course. I did my HAZWOPER training, like every medical toxicologist. But I never realized that I would be actually today sitting here talking about these agents with such relevance to our current present. And it's really sad that we are doing this today. And it's really sad that these events are still occurring. They are no longer rumors, whether they are occurring or not. I remember when I first became involved in this topic, I became involved in this topic through my origin as a Lebanese citizen growing up in Lebanon during the war between 1975 and 1990. I only moved to the U.S. in 2000. So I became involved in this topic through my connections with physicians from Syria. When the first reports came out of potential uses of chemicals in the war, and those were rumors initially. I remember watching the videos in Arabic. I remember reading recounts of the clinical signs and symptoms of the patients, of the victims, by colleagues from Syria. They were sending them. And there was initially some doubts that these were actually happening. But we are way beyond that today. Unfortunately, these events have been confirmed. The use of these chemicals is confirmed by international organizations, and they are even now being published in journals. Like you see in this journal is already publishing a case series of exposure to these chemical agents. So this is quite indeed a sad present that we are in. Of course, these chemicals have always been posing a threat. Of course, in the state of Alabama, we are well aware of the mitigation of the threats in the Anniston, incineration project, the Army Depot. Yeah. So we are well familiar with that. But occasionally we would see these chemicals causing harm. We used a lot of these chemicals in World War I, and then after that, the military disposed of this ammunition in the ocean, in international waters and even domestic waters. Some of it also was buried. And so we have thousands of these ammunitions with sulfur mustard or with nerve agents that were dumped at different locations at different instances, dozens of instances that were reported by the U.S. Army. The largest of which was in the 60s, I believe. I may be wrong on the date, but in the 60s, thousands of these ammunitions were dumped across from the coast of New Jersey. And occasionally we'd find a fisherman, for example, pull out by mistake a shell and get exposed to the chemical. And this happened a few years ago, actually, when a fishing crew got exposed to sulfur mustard. And their initial presentation was misdiagnosed as maybe a bite or an insect bite. It wasn't until a few days later that it was really confirmed to be a sulfur mustard exposure. So they do occur. And also, they can be a mass casualty incident. For example, in China, and this is not just a U.S. problem, even in China, where there was a war with the Japanese who used sulfur mustard and lewisite, they were digging a site for a parking deck. And they came across some barrels that contained lewisite and sulfur mustard. This led to 44 victims and 1 death. So you can see the significant skin burns that they developed, as well as chronic complications. Now, of course, this is no longer a 1 or 2 incident. Of course, now we are living in a world where these are much more common, unfortunately, like I said already. And the Syrian Arab Medical Society has published a really detailed recount and report of these uses. It's available for download for free. You can look for it on the internet, the Syrian Arab Medical Society report. And they have documented 161 chemical attacks in Syria with 14,000 injuries and 1,400 deaths. This is certainly a number that will shock any of us nowadays. And the chemicals that were used initially were the, if I may say, the single use or the specialized chemical warfare agents like sulfur mustard and sarin. But then after that, we saw an increase in the number of attacks using chlorine, for example. And then we'll get into more of that in a few slides. This is not only in Syria. We have also seen the use of these chemical agents, particularly sulfur mustard and chlorine, in Iraq. And one of my colleagues, Dr. Ala Mohsen Humaydi, who I credit for some of the content here, he used to be the director of the CBRN Center in Baghdad. He shared with me this list of incidents that he documented. You see this varies from burning the sulfur mines and releasing sulfur, using blistering agents such as sulfur mustard, chlorine, and affecting a large number of victims as well. So this is why it's really important today to try to focus our attention on a few objectives. I am going to go through this content with the purpose of providing you with the tools to at least list these chemical warfare agents, discuss some of their clinical manifestations, try to identify what the signs and symptoms that they cause. We'll discuss their management, challenges in their management, and how we can potentially improve our response in that category, and also use some historical or recent events just to illustrate. And I hope we can make this as interactive as possible, Tim, so that our audience is not losing focus, because it's really hard sometimes through a satellite broadcast or a webinar. So before I start, I'd like to just maybe define what is a chemical warfare agent. What is it? Well, first of all, there are millions of chemicals, as we all know, and they don't all qualify under the strict definition of a chemical warfare agent, although any chemical can really be used to inflict harm. So a terrorist can use any of these millions of chemicals to inflict harm and injury and death on innocent people. But chemical warfare agents are typically thought of when we're thinking about a very toxic chemical agent, very potent, where a small amount can lead to severe injuries and death. This is what you should think about. The dose here is very important. The small dose, and some of these chemical warfare agents are easily dispersed. Those are two properties where the military scientists, when they come up with these agents, they try to pick a chemical that is very potent and that is dispersible, because their purpose is to affect the enemy military using that chemical. But again, the dose is very important, and that applies to any of the chemicals. So when you look at a chemical scenario and you try to assess the damage and the potential risks and hazard, you must look at the agent properties. You must look at the potency, which we just mentioned. But you also must look at the physical properties. That's what I do as a toxicologist. I read the physical properties of that agent. Is it going to be volatile at room temperature? Is it going to be freezing? Is it going to become a liquid if the temperature is low? Right. That's an important limitation of sulfur mustard that we'll talk about in a little bit. You want to know if it's a solid. Is it a liquid? Is it a gas? Cyanide gas, for example. These are important components. And the amount that is being used. A large amount. Is this a small container? Is this a large barrel? What are we talking about here? What is the volume that we have available? And then what is the environment of the release? Are we looking at releasing a chemical in this studio right here? Are we looking at doing this in an open field, at a football field, for example? Right. And then who are the victims? Are these victims wearing MOPP gear or protective equipment already? Are they soldiers that are wearing the appropriate protective equipment? Are these innocent civilians watching a football game? Right. So we must look into this to better understand the effects and better build and plan our response. So this is essential because it's really hard to prevent these events from occurring. I know many of these highly potent chemical warfare agents are very secured, very regulated, but the rest of the chemicals, even the precursor to these chemicals, precursors that are used to make these warfare agents, may not be as secured. And I think there's an important effort that is going on in the US and around the world in securing chemicals. So the topic of chemical security enhancement is essential.
Yeah, and like chlorine is so readily available.
Exactly. Chlorine is so readily available. That's a perfect example of what we call a dual-use agent. When you hear the term dual-use, it means that it is used for chemical warfare, but it can also be used for industrial applications, like paper industry or chlorination of pools. So that's a dual-use agent. Compare and contrast that with sulfur mustard, which has no real industrial use. It's a single-use agent.
Right, and chlorine would also be pretty cheap for someone who wanted to buy it for nefarious purposes.
Exactly. You're right on track there. And preventing these requires us raising awareness about them, requires our chemical industry to improve their ability to have inventories, secure storage, knowing who has access to these chemicals, knowing who your customer is if you're selling a chemical, knowing who that customer is, and safe transport, and maintaining the production chain, and being careful and looking at those precursor agents that could be used as well. And then in the response to these chemical incidents, we also have a lot of challenges. And our emergency responders who are watching today are the first to really appreciate these challenges. I know that they are always putting themselves at risk for the safety of the public, and we certainly salute them for that. But when you are responding to a chemical incident, it's much more challenging for them. Because first of all, how are they going to realize this is a chemical incident? I mean, there are some scenarios that are easier than others, but some are not easy, especially with chemicals that are more insidious in the clinical manifestations or have a delayed effect. Right. So how are they notified? How are they activated? How do they recognize this as a chemical incident? Do they look at funny colored smoke, or do they look at the signs and symptoms of the patients? When I first saw the videos from Syria, it was obvious there was something wrong. These people were exposed to a shell, a bombing. They had no traumatic injury, and yet they were unconscious, and they were having secretions, and these are potential clues that there's a chemical incident that is involved. our responders also have to think about their own safety. And chemicals can be dangerous to the responders, depending on the potency of the chemical. So how do they make that judgment call? Well, of course, you want them to have the hazmat team. You want them to have the hazmat suits on, like a level A personal protective equipment, ideally. But is that always available? And how much time does it take to get that hazmat team on the scene? In the meantime, what do? Do you use a level C with an air purifying respirator, or do you just use a mask? And these are challenging, very challenging for our responders. And then with that said, they're on the scene, they are safe, they've put on the appropriate PPE, and now they have to do triage and transport. That's a whole different story too. Triaging the victims in the mass casualty incident, applying a specific mass casualty incident triage like the START or the SALT, right, whatever system you use. And do you decon on the scene? Do you decon at the hospital? Of course, we prefer the decon on the scene, at least disrobe the clothes, right, and decon on the scene. But we all know that some civilians, victims, will just leave the scene and will go on foot or use another mode of transportation to go to the nearest hospital, non-decontaminated.
And self-present.
Self-present, and that's the problem that hospitals have to actually think about. That's a challenge to the hospital. So, do you decon at the hospital? And I know our responders are much more alert to this, probably, than our hospitals. Because our hospitals are sitting there seeing chest pain after the other, stroke after the other, and then somebody shows up with an unusual symptom. Our responders are probably much better at recognizing, because that's what they do, and that's what they look for. But a dispatcher in an emergency department may not realize that this is a chemical incident. Yeah. If they don't ask the information, or if the information is not communicated to that person, this may go unnoticed. And then once you're inside the hospital and you do your decon, like I said, if it wasn't done, now what do you do with the management? How do you diagnose what's going on? Right. Some of our colleagues in emergency medicine don't see this very often. I'm a medical toxicologist, and there are about 600 medical toxicologists in the United States. That's not enough to provide this expertise. We do our best through poison centers, through us being at hospitals, like I am, for example, at Grady Hospital in Atlanta. But still, you need the specialized expertise to become more available. I know in the radiation environment, we have created radiation injury treatment network centers. There are about 60-plus hospitals in the country that have this expertise. We don't necessarily have that for chemicals. So just something to think about for the future. We do have burn centers that could handle some of the chemical burns, but we don't really have chemical care centers. We have this concept of toxicology centers of excellence that hasn't been fully fleshed out. But essentially, you would need a solid team of medical toxicologists, laboratorians, pharmacists. You'll need responders with expertise in PPE and decon, emergency managers to build such a center. And then after all is said and done, public health comes in and tries to do a long-term monitoring. Now, that's really tricky. We can spend the whole hour talking about how do you do a monitoring as a public health for 1,000 people, right, 2,000 people. What do you look for? What medical illnesses do you monitor for? What diagnostic tests do you use? Are they reliable? Are they available?
Right. And this could go on for a long time.
Long time.
Which takes a lot of manpower and money to do.
Absolutely. And the commitment has to be for the long run before you decide to do it. So all of these are challenges, I think, that we face. In the emergency department, we are looking at these patients and we're saying, what is the best diagnostic test for this disease? And I have plenty of tests in my test bag or in my computer that I can send out. Troponin for a heart attack. I can send a CPK for rhabdomyolysis. I can get a chest X-ray. All of these are great. But if you're exposed to methyl ethyl ethyl, and I have to test for that, I don't have a test for methyl ethyl ethyl. And even if there was a test for that chemical, I have to probably find the appropriate specimen. I have to collect it. I have to ship it to the lab. Say you go to a commercial lab, and that would come back 2-3 days later when it's not useful. Right. Now, luckily for us, we have some air analyzers that are used on the scene by our responders. Hazmat teams will try to send us some information, but we must be very careful with these. And I'll provide a couple of examples today about where these tests could be wrong, because they are not perfect. Like I said, there are 80 million chemicals out there. So there's a lot of overlap, there's a lot of false positives and false negatives. And therefore, the clinician, I recommend, and the way I teach my fellows and my students and my colleagues in emergency response, I always recommend to rely on your clinical assessment, not on the lab. And I've been in situations where I was consulting with international governmental agencies like ministries of health, building toxicology capacity in their country, and they always focus on the lab. And I always tell them the lab is important to confirm, but before that, you cannot just rely on the lab. Having a lab is not sufficient. You need to have the clinical training, the clinical expertise, the assessment to do that. And CDC has recognized that years ago. My colleagues at the National Center for Environmental Health published this in 2003 that you can actually get online for free, which is a recognition of illnesses associated with exposure to chemical agents. In other words, toxidromes. Basically, they are teaching us to look for a toxidrome and try to manage the situation according to our recognition of this toxidrome. And they list several toxidromes that I transcribed here in an easier way, more visible way, to show you some of the ones we're going to cover today. But this is a long list, I know, but maybe we can read it. You know, a toxidrome is a collection of clinical signs and symptoms that point to a toxic agent. They could be wrong, but they point.
Right.
A toxic agent or a class of chemicals.
Well, and I see up here, you know, the buzzword of today is the opioid crisis that we're
Absolutely.
dealing with.
That's the opioid toxidrome that responders are really doing a great job looking for and treating when they see it with their antidote, which is now in their possession.
Right.
So that's an important one. We'll cover it at the end a little bit. But I'm going to primarily focus on the irritant toxidrome, which is the most common or the most likely scenario. We will talk about the asphyxiant toxidrome a little bit, the cholinergic toxidrome because of its importance and recent use. We will not talk about the anticholinergic toxidrome. Think about Jimson weed here, or BZ, or atropine. This is the anticholinergic toxidrome. We will cover the vomiting toxidrome because of its relevance to the arsenicals that we are researching at UAB in Birmingham. I mentioned the blister toxidrome or the vesicant toxidrome. We will cover that. We will not cover the corrosive or caustic toxidrome. This is, think of somebody attacking somebody with sulfuric acid. We've seen that in criminal use in India, for example, or Pakistan in recent history. Even in the UK, we saw an acid attack recently. We will not talk about the sedative toxidrome, but this is similar to the opioid, but think about here GHB, for example, or a benzodiazepine. We'll cover the opioid toxidrome briefly. We will not cover the stimulant or hallucinogenic toxidrome. Think of amphetamines, think of ecstasy for the hallucinogen. We will not go through these in details today because of the time that we have allotted. The National Library of Medicine has produced a very important resource that every emergency responder should visit and even download on your phone. This is the Chemical Emergency Medical Management, CAM website. Has a wealth of resources, and I'm showing you on the screen the intelligent syndromic tool, where you actually put in some signs and symptoms, and we'll give you a probability of what toxidrome it is. But let's go ahead and start with the irritant toxidrome, if that's okay.
Sure.
And if there are any questions, please let me know, and I'm happy to address them as they come. But the irritant toxidrome is very famous. I mean, this is the most famous toxidrome. It's a pretty broad toxidrome, and it's caused by a large number of chemicals. They're not all the same chemicals. A broad range of chemicals will produce an irritant toxidrome. And an irritant toxidrome is really essentially irritation, the way as its name says. It's an irritation of your mucous membranes and your respiratory system. Okay? And it's quite famous because it was first used in World War I in the Battle of Ypres in 1915, where the Germans used chlorine. So chlorine is the foster child of, is that the right term? A great example of an irritant chemical. Chlorine was used, and then phosgene was used after that because it was considered to be better than chlorine, and caused thousands of injuries and death in World War I. The importance of this irritant toxidrome is that it can be released on the military field, but it's not easy to direct its direction of spread. As you know, the wind changes, wind direction changes, and you see it was a pretty simple way. They basically had chlorine barrels, and when the wind was blowing in the right direction, they knew that that was the time to release to open the barrels, and they would open them, and then the gas will be released. It's pretty basic method, and it hasn't changed much. This is the same type of release in Iraq. So it's interesting how history has not changed the use of these barrels between 1915, and this is a recent photograph of a chlorine bomb in Iraq provided to me by Dr. Ala Mohsen Humaydi from Baghdad. So the importance of these chemicals, and this is something that I hope my responders on the webinar today will listen to carefully. It doesn't matter what the chemical is. You can predict a lot by knowing the water solubility of that chemical. So I'm going to explain this very important principle. Water solubility will tell you what predominant symptoms you may see with these toxidromes, with the irritant toxidrome. For example, let's use chlorine as an example. Chlorine has an intermediate water solubility. So we can consider it high, if I may. The moment chlorine reacts with water, and where is water? Water is in your eyes, in your nose, in your mouth. If the water solubility is high or intermediate, the reaction with water of the chlorine will be very fast, and it will rapidly release hydrogen ions. These hydrogen ions cause the cell damage and make you feel that you are exposed to the chemical. The pain is that reaction between the hydrogen ion and your throat.
Immediate.
And what do you do when this happens? And we probably had that situation when you go into an indoor pool if the weather is bad on one of your vacations on a resort. You end up going to the indoor pool and you open the door and you get hit by a little irritation from the chlorine that was used in that pool in an enclosed space. Typically what do? You actually walk away and potentially you hold your breath. So these highly water-soluble, intermediately water-soluble chemicals that are irritant, if the dose is not overwhelmingly large, you get to run away from it, and you limit your exposure and symptoms, your toxidrome, to the upper airway and mucous membranes. Compare and contrast that to phosgene. Phosgene has low water solubility. It reacts with water, it releases the hydrogen ion, and that's what causes the damage, but it takes some time. So it doesn't hit you in the face and the throat. You inhale it. It goes inside. Now it starts reacting here, it's already reacting, but slow.
Right.
Same in the lungs. But you don't run away from it. And then it will cause severe pulmonary edema or severe pneumonitis, severe damage to the lung. I say it's pulmonary edema, but that's not an accurate term. It's inflammation and lung damage and injury from this hydrogen ion interacting with your cells. Now that said, don't think that chlorine would not cause the lower airway injury as well. We've all seen in Grantsville, South Carolina, when the chlorine was released, and even in this case that I took care of, that I'm showing you on the screen, that I took care of in Atlanta, this was a person who was running away, was hiding in a storm drain, was exposed to zinc chloride smoke bomb, which is also an irritant, produces an irritant gas, hydrochloric acid. And he developed severe lung damage with his chest x-ray, with his pneumomediastinum, pneumothoraces, was intubated for about 20 days, ventilated for 20 days, was discharged eventually with limited residual lung function. And remember, these chemical irritant exposures can lead to a long-term effect that would be subject to a public health monitoring plan called the reactive airway dysfunction syndrome. And in our clinic in Atlanta, we saw many of the survivors of the Grantsville, South Carolina incident in our clinic because they developed reactive airway disease and lung complaints that may last several years. So that's another area where you should think about doing population monitoring. So that's, unfortunately, the irritant toxidrome doesn't have any major management except providing the supportive care with oxygenation and ventilation, securing the airway, and treating any secondary infections. But there's no real antidote for this. And I know now there are some centers in the country, similar to the center we have in Birmingham, working on chlorine and medical countermeasures. The next one that I want to talk about is the vomiting toxidrome. This is what we are focusing on here in Alabama at UAB with our Counteract Center. With our principal investigator, Dr. Mohammed Athar. He's leading this effort, and I'm participating in the education piece of it. This vomiting toxidrome is due to chemicals that we call arsenicals, and because they contain arsenic. There are a few of them. The most famous of one is adamsite, which you see depicted there. There are 2 or 3 more that we are working on in Birmingham. And the interesting thing about this vomiting toxidrome is that although it's called a vomiting toxidrome, it does cause irritation. And the interesting thing too here is that the irritation is a little bit slow and delayed, kind of like phosgene, but not as delayed as phosgene. So a soldier will be exposed to this gas, will not realize it for the first few minutes. So the soldier will get a dose of it. Then they realize they're exposed, they put on the mask. But then the effect is not short, it's delayed and it's prolonged. So they'll have prolonged effects with fatigue, chills, malaise, fever, and vomiting. This is why it's called the vomiting toxidrome. Now the vomiting is not 100% occurrence. We don't have a lot of information about this. This is why Dr. Arthur at UAB was able to get this important research grant to study the mechanisms whereby these chemicals cause their injury. And he is working on developing drugs that could counteract their effect. So these vomiting agents are called vomiting agents. They do cause irritation. They do cause vomiting, but not uniformly. And they do have these delayed effects and prolonged effects. And I think we don't have a lot of experience in them. That's why we're researching them, because there have only been 2 reported deaths, primarily accidental. One time was in a barrack where it was released by mistake. Caused 1 death. There's another report with another soldier that died from it. But these are old reports from the 1914, 15, 20s, and we don't have enough information from them. Next is the king of toxidromes in World War I, the vesicant toxidrome. Now this is the king because it caused the largest number of injuries in World War I, primarily sulfur mustard. And it was introduced in 1917, and it has a regular form, and it also has a distilled form. And like I said, caused a large number of injuries, but with a low mortality. The mortality was less than 5%. But the illness was so prolonged that the soldiers were out of function, out of duty for a couple of weeks, and they required a lot of hospital resources to care for them. And this vesicant toxidrome, I'm showing you here some pictures of sulfur mustard from Iranian soldiers attacked by the Iraqis. It causes the classic skin effects. We call them the blistering agents, or the vesicants. Of course, it's going to cause skin effects, and you see the blister over there, and the erythema on the chest of the soldier laying in the bed. But they also cause effects on the eyes. We see the conjunctivitis there, the erythema, the swelling, the edema. That could lead to permanent damage, and also cause pulmonary effects. And sulfur mustard is interesting to us because it is going to affect these 3 organ systems: the skin, the eyes, and the lungs. And it's also interesting because it is going to react to change its properties a little bit depending on the ambient temperature. I mentioned that earlier. When you look at the agent-host environment, when you look at sulfur mustard, you'll realize that it has a low freezing point, a high freezing point, relatively high freezing point. So at a low temperature, environmental temperature, it will be like a liquid, and therefore it will not vaporize very well, and you will not get potentially a lot of the respiratory effects or the eye effects. But in a warm environment, you will get the eye effects. That's why you saw a lot of the eye effects and pulmonary effects in Iraq and Iran, because of the temperature there in the Middle East. This is a problem for use of sulfur mustard, because if you are going to use it in Russia or in Japan, where maybe the temperature is very cold, you have to add to it a solvent, and that's what they've done. They've added to it oily solvent, or even lewisite, which is another arsenical that we will talk about shortly. But that's interesting to remember, the physical property of mustard. The effects, like I said, will take a while to develop. So the initial symptoms are going to be dependent on the dose and the temperature in the environment. But you may have a delay of 24 hours before you see the blisters, very painful blisters. They may be preceded with some itching initially that they can feel. The earliest thing you could see potentially is the eye effects and the lung effects, followed by the lung effects. Right. But that caused delay in the toxidrome. Important thing to remember for our soldiers, and it can go through clothes. And it likes areas that are moist, so the groin or the axilla would be preferable targets for this chemical. And no treatment. And there's no treatment for this sulfur mustard. Again, the Counteract program is looking at novel therapies for these treatments. Essentially, you treat them as a burn wound. You unroof the blisters, and then you treat them like a burn with antimicrobial dressings, and if they need to be surgically excised, the burn wound needs to be surgically excised or grafted, you will have to work with your burn surgeons for the appropriate management of these. These are some pictures that Dr. Ala sent me from Iraq recently. This is a soldier that apparently was carrying, he found a sulfur mustard canister, and he was carrying it on his shoulder, and it leaked and caused these blisters on both sides of his shoulder. This is some more horrific blister pictures of this child's arm, and you see the face and the eyes and the neck. Again, these are courtesy of Dr. Ala Mohsen Humaidi. I was not able to include them in the handout because they are his pictures, and he allowed me to show them today just for our viewers. The next one is lewisite, that is a vesicant as well. And lewisite is an arsenical. You see the arsenic atom in there. It was developed in World War I, but didn't get a chance to participate in World War I because World War I was over by the time it arrived to Europe. So we do have experience with it, though, from other scenarios. And it was developed with an antidote, a British anti-lewisite, which has some applications, but not enough applications and not enough efficacy. This is why our center in UAB is working on developing new antidotes for lewisite, which is interesting. It varies a little bit from sulfur mustard because it causes rapid onset skin effects. So it's more immediate effects than mustard that is delayed. And I could also mention phosgene oxime, which is also a vesicant. Doesn't really cause blisters. It causes more like wheals of erythema, but also is another immediately acting vesicant agent. And here are some interesting pictures about lewisite, which smells like geranium. And again, some of this lewisite was dumped in the ocean by our military after World War I was over. We're getting towards the end here. If there are any questions, let me know. But I want to talk about the cholinergic toxidrome. This is an important toxidrome because of its recent occurrence in Syria and in Malaysia and in the UK. Historically, this cholinergic toxidrome is caused by what we call the nerve agents. Nerve agents that are essentially organic phosphorus compounds. We are more familiar with organic phosphorus compounds in agriculture because they are used as pesticides. And they are the most common cause of death from suicide, one of the most common causes of death from suicide in India, for example. We have less of these cases in the US because they are very restricted in their use. And fortunately for us, we see less of these cases. The nerve agents are organic phosphorus compounds that were developed by the military as single-use agents to be very potent. And the classic one is sarin, but there are others. There's soman, there's tabun, which was used in Iraq against the Iranians. There's cyclosarin, and there's VX. And I would like to just talk about two of them to compare their physical properties. When I was a fellow, I spent some time in the Center for Domestic Preparedness in Anniston. I took the Technical Emergency Response Training course, the COBRA course. And at the end of that course, you have the amazing opportunity to look at to test liquid sarin and VX with a military paper, the M paper. And of course, you're wearing your PPE and you're doing this test. And I remember clearly, you stay there about 10 minutes maybe, 10, 15 minutes. I don't remember exactly how long we stayed, but I remember that by the end of my experiment, the Petri dish, the dish that contained the VX was still there. It looked like oil, like olive oil, whereas the sarin Petri dish was empty because it evaporated. So this is a very essential property. Sarin will evaporate, soman will evaporate, tabun will evaporate, VX is persistent. That's very important to remember. And VX that doesn't mean VX is not dangerous. VX is very potent, and smaller than a drop on your skin can cause death. It will absorb through the skin and will cause its effects. Sarin also will be absorbed through the skin, but it will also hit you by inhalation. And this person that I have a picture of, this criminal whose picture is displayed, his name is Shoko Asahara. He was an extremist ideologist in Japan, and he led the Aum Shinrikyo cult that developed chemical warfare capabilities, and they had a chemical plant and manufactured sarin and VX. And they tested sarin in Matsumoto And then the following year, they tested it in, I think it was in 94, and then in 95, they did the big attack in Tokyo, sarin. And in that attack, they had 10 criminals work in teams of 5, so 2 per team, getaway driver and a delivery person. They delivered the sarin in bags and punctured them with umbrellas on 5 metros in Tokyo. And then they ran away. One of them, actually, the chemical engineer, for some reason had 2 bags. And he punctured the 2 bags and he got exposed. And then he had to go get treated in the Aum Shinrikyo hospital by the getaway driver. They caused about 12 deaths in that incident. In Matsumoto, I think they caused 7 or 8. But of course, there were about 5,000 injuries from this incident. I want to talk about this a little bit more. I know we're close to the 20-minute mark, but I think it's interesting to just go through the timeline a little bit. And I don't have exact timelines right off the back, but I'll just take you through this a little bit. This is for our responders and for our hospital-based responders. The chemical was released between 7:46 and 8 a.m. Terrible time. The first patients that showed up to St. Luke Hospital close by, I think it took them about 22, 23 minutes. They showed up on foot, by foot, on their own. The first EMS, I think, arrived about 40 minutes later with a cardiac arrest. So as we know, the sicker ones come in later. Right. And the first group comes in, you know, by their own means of transportation. The police knew that something happened. They thought it was an explosion. So the nurses and doctors thought this was a carbon monoxide situation, a burn situation. So there was no decontamination. All these people were just brought inside the emergency department without any decontamination. The on-scene command realized that there's some sort of chemical there. Their chemical test lacked the nerve agent module, and they identified acetonitrile, and they reported back that this is acetonitrile, which is a cyanide, causes delayed cyanide-like effect. Right. The doctors and nurses were like, this doesn't make sense. It's not looking like that. This is why it's so important for us to look at the toxidrome, not just the information that we get. And then there was on TV crews and everything, a doctor from Matsumoto who cared for the patients the year before saw the footage, and he called and said, this is sarin. So this is a great example. I like to tell this story. And they had, you know, hundreds of patients show up to this hospital. 500 patients show up in the first hour. Definitely a deluge of patients, a mass casualty incident. Unfortunately, the decon could have been done better. You had a large percentage of the responders at the hospital become affected as well with secondary exposures to these potent agents, which you think of them as vapors. They should not necessarily cause a secondary effect, but because of their potency, and you don't disrobe the patient, and you don't use any PPE, and you don't do any decon, affected about 20% of the healthcare providers at the St. Luke Hospital. There's a lot of interesting research on that you can look up and then get some more information if you like. Now, fast forward to 2013, Khan al-Asal was published as a report in Disaster Medicine Public Health Preparedness by a colleague of ours from Syria, who is actually currently living in the U.S. 20 people were killed, and an additional 124 were injured. And I spoke with that physician. He explained to me when he was there working as a medical student, he was a medical student there, that they were really uncomfortable with some of these clinical management. They had no PPE, they had no oximes, they didn't have atropine, but they weren't sure how to use the atropine, especially with children. So there was a big need for education, antidotes, PPE, and that was something to remember. And also they had secondary exposures of healthcare workers. Potentially, we don't have a lot of details, but they complained of some symptoms, and one healthcare worker had a cardiac arrest, which, when this happened, it made some of the healthcare workers hesitate to work, to continue working. So that was published by Dr. Qa'dan, and I invite you to download it and read it. And I salute him for his work in Syria. Now, for this decontamination knowledge, we now have recently a good resource. I don't know if some of our responders may have already seen this, but I thought I'll share it with you. It's also available on the CHEM website. The PRISM, which is evidence-based decontamination guidance, where now the recommendation is to, of course, disrobe, do dry decon, followed by a little wet limited wet decon followed by technical decon if necessary. And you can get more of that information in the PRISM, as well as the Aspire, which is a software where you can actually put in your chemical, if you knew what the chemical was, and when you were exposed to it, it will tell you what to do. So these two resources, I think, the PRISM and the Aspire, I hope that they can look at their leisure. I don't think they're in the handout, because I just added them this morning.
Okay.
So, so they can just remember to look for them. They're pretty easy to find on the Chem website. Then I want to mention, just out of the horrific nature of this attack in 2013, turning point in Syria where 1,300 deaths from sarin. And this was a turning point in the war in Syria because this is when Syria joined the Geneva Convention. Unfortunately, this didn't stop the Syrian regime, and this was followed by the use of chlorine and a severe increase in number of chlorine attacks. The cholinergic toxidrome is interesting. It is due to the inhibition of the enzyme that breaks down acetylcholine neurotransmitters in your body. This enzyme is called the acetylcholine esterase, and it's inhibited by the nerve agents. And this inhibition becomes irreversible if time passes. Time passes and the inhibition undergoes aging. We call it aging, and then it becomes irreversible. And what you see in the signs and symptoms is you see your acetylcholine excess in all organ systems. And the mnemonics to remember that is the dumbbells or sludge. You can use either one: sludge, salivation, lacrimation, urination, defecation, gastrointestinal upset, and emesis. Dumbbells is diarrhea, urination, meiosis or mydriasis, bronchuria, bradycardia, bronchospasm, emesis, lacrimation, salivation, or sweating. And I'm sure our paramedics are familiar with this. There's also the nicotinic toxidrome, which is Monday, Tuesday, Wednesday, Thursday, Friday. M for mydriasis or meiosis, T for tachycardia, W for weakness or paralysis, because people stop breathing. Thursday for the H for hyperthermia or hypothermia, and then the F for fasciculations. And the fasciculation and the respiratory failure are very dangerous. They kill you. And of course, the bronchospasm, bronchuria, and bradycardia, we call them the killer bees because they also kill you. People die in their secretions with bronchospasm. You can't ventilate them, you can't oxygenate them, and they die. And I show you here a patient that I had in Lebanon. Like I said, I do telemedicine for the American University of Beirut. And you'll see how this patient who ingested chlorpyrifos, this is not a nerve agent, it's a pesticide, developed this fasciculation of his arm. And we treated him with atropine and pyridoxine, and he got better. These are the antidotes for the cholinergic toxidrome, is atropine and pyridoxine. Unfortunately, we saw this again in the public space. We saw VX in the assassination of Kim Jong-nam, a cousin or a relative of the current leader of North Korea. They applied to his face 2 binary agents, 2 precursors. Remember I told you about the precursors? And they mixed them on his face, making VX, and leading him to die within minutes because he realized something was happening. He went to the clinic and in the hospital and then collapsed. And there's a video online, you can look it up if you like. The interesting thing here too, that he carried on him apparently atropine. So I don't know why he had atropine on him. But he had atropine, but that wasn't used. He just collapsed and died with cardiac arrest. And then we saw in March of 2018, the use of the newbies. We call them newbies, the Novichoks, which means newbie in Russian. These 4th generation nerve agents, or A-series nerve agents, they were used to assassinate Sergei Skripal and his daughter. They were found on a bench, unconscious. Julia recovered. They had signs and symptoms that have not been published well, and we haven't been shared. We've only received some anecdotal evidence, stories or news-based evidence about how this happened. But then we saw Don Sturgis and Charlie Rowley get affected in June, so several months later, when Charlie Rowley, who collects trash, found a perfume bottle that he offered to his girlfriend. So he found a perfume bottle in the trash, gave it to his significant other, and then she sprayed it. And you know how when you have the perfume, you're just gonna like try to smell it, and this is how she got exposed. He got exposed with it as well. And just to show us that this chemical is persistent, you know, obviously it survived in the trash can between March and June,
right,
and still caused effects. We don't know much about these chemicals yet. We know they're potent, probably more potent than VX. It looks like they're persistent. Looks like it's a liquid. But is it vaporizable, or what is the vapor pressure? I don't know. I don't have this information. But the Chem website has recently published several guidelines that are listed there that are essential for our responders. There are some for responders and then some for the medical management about the Novichok, or the fourth generation nerve agent. So I invite you to also download this document and look at it at your leisure. Finishing up with the asphyxiant toxidrome. This is what you would see from carbon dioxide, carbon monoxide, hydrogen cyanide, hydrogen sulfide, sodium azide. This is basically a situation where your body is no longer able to use oxygen. And when you don't use oxygen, your brain and heart get affected. Your brain, basically, you collapse, you become comatose. Your heart becomes affected, you become tachycardic, initially hypertensive, but then you you run out of gas, and you go to bradycardia and cardiac arrest. Right. We call them the knockdown toxidrome because they're sudden, rapidly acting effects, and people die rapidly. And they develop lactic acidosis. You can test for that using lactic acid test in the emergency department. And you can treat cyanide, for example, with the antidote hydroxycobalamin or some of the other antidotes which induce methylglobinaemia, like the sodium nithiodate, I'm sorry, which is sodium thiosulfate and sodium nitrite, which are in an antidote called nithiodate. Carbon monoxide is treated with oxygen, and hydrogen sulfide doesn't have an antidote, but there's some work being done on hydrogen sulfide. And then sodium azide also doesn't have an antidote. So this is the asphyxiant toxidrome. And last but not least, we are all familiar with the opioid toxidrome, your meiosis, your decrease in respiratory rate, decrease in oxygenation, your decreased mental status, your decreased temperature, your potential hypotension and constipation. All of these are part of the opioid toxidrome. And currently we are recognizing that on the scene and treating it with the antidote naloxone. Yeah. I'm on the board of the American College of Medical Toxicology, and we published recently a position statement because of the concern of our responders of fentanyl and other fentanyl analogs and their exposures to them. I know there have been some reports of serious exposures, serious health effects, or serious health consequences to our responders, like law enforcement, from touching the powder. And the ACMT reviewed all the evidence for that to reassure our responders that this is unlikely to be the case from just touching some powder on a victim. It is really more concerning if they're actually inside of a opioid manufacturing lab where they're making these fentanyl analogs, where there's very high concentrations. Right. Especially if there's a bomb thrown in there, like a sound bomb that can vaporize some of that.
Get it airborne. And
then you can potentially use a air purifying respirator, but that's not necessary in the emergency department or on the scene of like a regular, say for example, arrest. Of a user of the drug, not a drug maker, right? Somebody who's using the drug. You can consult that position statement that was created by ACMT and in collaboration with the American Academy of Clinical Toxicology, and it's available for you to look at.
So in this situation, we go back to what you said earlier about dosage.
Absolutely, yeah, exactly. Dosage, and then is it vaporized? Right. If you touch it, is it going to go through your skin? Certainly wear gloves. If you have a mask, a surgical mask, it's fine. An N95 if you prefer. So, but in summary, the chemical warfare agents, of course, are numerous, and they can cause serious injury and death. It's important to remember that these are no longer a historical chapter that we read just because we're completing our education. This is a reality. There's a threat, and we need to be familiar with these toxidromes and guide our assessment and management through that approach, because the lab detection is going to be delayed and unreliable. And we should do our work safely, effectively, using the approach described today. And I hope we have some questions to discuss.
Sure. We have a question about countermeasures. So how would you get countermeasures to people who are affected? What are some of the challenges in getting them to the people who are affected?
That's a great question. You know, I don't think there's an easy answer. There's a lot of effort in that direction, and I think Tim also may have some comments about that, considering your role in the state of Alabama. But getting the antidote at the right place at the right time is essential. That goes without saying. We have the Strategic National Stockpile that has a cache of antidotes. For nerve agents, we have the ChemPack program, which is a cache of atropine and pyridoxine and benzodiazepines, I believe. Those are available in every state. Also, it requires some time to be delivered, but certainly closer to where they will be needed. The hospitals may also have some antidotes that are available, and they may even have some antidotes that they are not aware of their potential use. For example, there was a recent paper published by Dr. Michael Schwartz and Dr. Kirk from the Department of Homeland Security, also on the Chem website, again on the Chem website, that talks about using alternative therapies. You know, for example, atropine eye drops. Atropine eye drops are present in hospitals. They can be used for a nerve agent exposure. It's the same atropine,
right,
and it's very concentrated. So if you consult that paper, you will find in it algorithm for management, what do you usually do, and then if you don't have it, what is the alternative? And they list these drugs. So certainly there are some drugs we already have at the hospital, alternative therapies that can be used. And then, as I said at the beginning, there are many chemicals that don't have an antidote, and all they require is supportive care, airway, breathing, circulation, you know, ABCs, and then any supportive therapy you need, whether you need antibiotics or whether you need vasopressors, and then intensive care.
Another question. What information do we not know about arsenicals that would be important for emergency responders during an incident involving chemicals?
Well, I think arsenicals, like I said, you know, the lewisite, for example, and the other ones, we don't have a lot of experience in them because they were not used in large amounts, and we don't have a lot of data. We have a couple of accidents in the 20s. So I think we're trying to find out what is the mechanism of action, how do they actually cause this inflammatory response, this tissue damage to the lungs, to the skin, to the eyes, and how they cause this avalanche of inflammatory effects, systemic effects. And that's taken a lot of work by the UAB Counteract Center in Birmingham that's looking at these mechanisms using animal models, porcine models, as well as mice. And they're applying to them lewisite, for example, and they're studying what happens at the microscopic level. And they have some promising results that I believe they will present in June at the Counteract meeting in New York, and potentially some therapies that they're working on.
Yeah, and I had a question. You know, it's exciting for us here in Alabama to understand that this research is being done up at UAB with this lewisite antidote, but with these Novichoks. I mean, is there once this information gets, because it's only been about a year ago, is that something that's on the horizon as well?
Absolutely. I think what you see on the Chem website, those 3 documents that were created for medical management and then emergency response, as well as technical information, is just the first step. You know, these chemicals were developed in a secretive way, and up till now, for example, the Russians are denying that they made those chemicals. They were confirmed in the UK that they were used. So I think now we need to understand how they work in animal models, and then and hopefully they will work the same way as nerve agents, and then we can potentially try to use the same antidotes, because we do have antidotes for that.
Right.
But I think there's many answers that need to be many questions that need to be answered in the next year or two. But this is not an easy process, especially when it's so secretive. But I have full confidence in our government and our scientists who will unravel this mystery for us.
Right. Well, it's certainly, you know, when you hear from what history shows and what we have new, it's nothing new, but yet we have these new threats that are out there, and we've got to be informed.
Absolutely.
So.
I think and more than ever, you know, we have to be aware of this. We have to also look at the signs, what's going on. I mean, we started using these chemicals in Iraq in Syria, and then we saw them in UK, so in an airport in Malaysia.
Yeah.
I mean, this is a warning to us. We need to heed the warning, and we need to do our best. I mean, us responders, you know, we can only do one thing, which is prepare ourselves to save lives safely. Yeah. And if we don't go through these type of training programs, and we don't take the time to listen to this and to go and do some personal research on the topic, we won't advance our knowledge. And when this happens, not if this happens, when this happens, hopefully we'll remember some of the important points that you went through today. You know, the most important one is the agent-host environment. Go through that assessment. Okay, what are the physical properties? What are we looking at here? Is this an inhalational hazard? Is this a skin hazard? How much are we looking at? Small amount, a large amount? What are we looking at?
Right.
Do we have an antidote? Do we not? What is the toxidrome? If we do that, if we do the agent-host environment, we do our toxidrome analysis. And we remember at least some of the stuff we talked about today. I think we will be able to manage that first hour. That is critical, because we will be on our own the first hour.
Right.
As resources are brought to bear, hour 1 to 6 or 24 or 48, I think we'll have more information and more confidence in what we're doing. But initially, we only have a few tools, and I hope that our participants today grasp these tools. I apologize if I speak a little bit too fast and I have an accent, and I hope I was clear enough. And of course, the handout is there for them to consult with later. And again, I'm happy to answer any questions. Here's my email, my Twitter account. Please follow me if you use Twitter, and email me any comments or suggestions so that I can improve my work in educating our colleagues in this important topic. And I thank you, Tim, for doing a great job moderating. And I thank the Alabama Department of Public Health and the UAB Counteract Center for Excellence in our Santa Cruz research.
Well, it was a tremendous amount of information over the last hour, and I know we have responders and receivers that watched live today, and hopefully this message will get out for those who want to watch on demand. But this does conclude our program for today, and I'd like to thank Dr. Yazzie for being here, and thank everyone watching our program. But please remember that you can refer back to the training and resources at any time on demand. Have a great day.
Thank you.